Good morning, respected judges and colleagues. Today topic of my presentation is brittle cornea syndrome, which is one of the rarest cases, and only 60 cases have been documented till now. So what is brittle cornea syndrome? Brittle cornea syndrome is a rare autosomal recessive connective disorder with ocular and auditory manifestation. The hallmark of this particular syndrome is the propensity to cause the corneal rupture after the innocuous trauma. The reason being the thin central cornea, almost less than 400 micrometer. The other ocular features that are present are keratoconus, keratoglobus, refractive high myopia, and retinal detachment abnormalities. BCS is of two types that occurs due to mutation in the transcription regulator protein, the first one being the zinc finger protein 469, and the type 2 that is PR domain containing protein 5. Moving on to our case, a 9-year-old female presented to our outdoor with the complaints of the gradual dimness of vision in both eyes with the history of frequent change of spectacles. Her family history was negative for any known genetic ocular and systemic disorder. As the pedigree chart shows, the inheritance was autosomal recessive type. Her uncorrected visual acuity was FC 1 feet and FC 2 feet, and her best corrected visual acuity was 6 by 60 in both eyes. The slit lamp examination shows the presence of blue sclera, horizontal scamus, thinning of cornea with both eye central corneal opacity. The features of keratoconus like Munson sign, prominent corneal nerve endings, Fletcher ring, and the Vox striae was present. Musculoskeletal finds examination shows long and standard extremities, hallux valgus, loose skin, hyperextensibility of small joints. Moderate to severe sensorial deafness and umbilical hernia was noted on systemic examination. The first most important investigation that was performed was corneal tomography, and it shows that the cornea was thinnest at the center with being 384 micrometer in right eye and 373 micrometer in the left eye. The Kmax in the both eyes were more than 50 diopter, suspecting it to be prone to develop the corneal ectasia. The other investigation that were done were tympanometry, pure tone audiometry, ultrasound, X-ray imaging. And the most important the investigation that was done to finally make the diagnosis was whole genome sequencing, which confirmed that there was mutation in PRD-M5 gene at the variant C1768, where the cytosine is replaced by thymidine, thus confirming our diagnosis to be brittle cornea syndrome type 2. The Sanger sequencing was performed on the patient and her family members. It shows that as the normal sequencing here, it shows that the cytosine is replaced by the thymidine in the patient. The brother and sister have the normal cytosine basis, and the mother and the father both have the cytosine and the thymidine basis overlapping. The intervention that we preferred in this case was medical management. The patient was asked to avoid the contact sports and love fleeing. She was asked for protective polycarbonate glasses. At present, the patient has not developed the corneal rupture. She's kept on the follow-up every 3 months, and her best corrected visual acuity is 6 by 60. There are many studies that are done on the particular syndrome. The most important being by the ophthalmologist Burkett Wright, and studies have revealed that BCS type 2 has more prone to develop the hearing defects and the musculoskeletal findings, and there are lesser chances of corneal perforation in BCS type 2 as compared to BCS type 1. We had kept the patient on the close follow-up with the serial corneal scanning and the other musculoskeletal findings. The clinical implication of this case being that this particular mutation, that is 1768, cytosine replaced by thymidine, PARG termination, is the first mutation to be reported and documented till now. Timely diagnosis and treatment is must, as if it is not timely diagnosed, it may develop the corneal rupture. Though the therapeutic methods like the contact lenses, keratoplasty, and collagen cross-linking are recommended, but the efficacy is unsatisfactory and limited. So we preferred for palliative and the conservative management. And since the particular disease shares common features like blue sclera and musculoskeletal findings with kyphoscoliosis, EDS, Ehlers-Danlos syndrome, osteogenesis imperfecta, and Marfan syndrome, so we need to timely diagnose and treat the patient before a corneal rupture occurs. Thank you.
Thank you, Ishita. The one point that I liked about your PPT is we prefer palliative treatment. Remember this point. In brittle cornea syndrome, any surgical intervention, usually you will be disappointed after that because you cannot suture, the cornea keeps on tearing during surgery. So palliative conservative should be the way to go for, unless there are some acute complication like corneal rupture. So Dr. Ritika, you had.
Yeah, no, the first speaker I think had highlighted that there was a the other eye was 6/6, myopia, of course, 6/6 with glasses. 6/12 is good vision. You just give these patients polycarbonate glasses, tell them to have lifestyle modifications which does not predispose them to much trauma, and that is the therapy that you give. For advanced cases, rather than do penetrating keratoplasty, of course if it's not ruptured, and epikeratoplasty has been documented by some, and earlier cross-thinking could not be done because these corneas were thinner and they did not fall as part of the Dresden protocol. But now with adaptive fluence, that basically means you're using lesser energy, people have started cross-thinking these corneas also. So these are therapies which are easier to do. Whenever you try and suture these corneas, they tear up, the graft rotates, and once you have an open globe in a penetrating keratoplasty and you're not able to manage to do a good graft, you are in a soup. So therefore, closed globe procedures and palliative procedures are best for these, right? Even if the cornea is 200 microns, then you do an epikeratoplasty over that rather than open the globe, and even 200 microns in today's adaptive fluence, you can go up to 200 microns to cross-think. Of course, adaptive fluence is a concept that has just come out, and people have not cross-think 200 yet, but that may be a future frontier.
And how much of the epithelium can we scrape out in such cases since it's
I'm sorry, I can't hear you. If you're talking about suturing, sometimes you have to take larger bites. You sometimes have to use 11-0 nylon and even almost go up to the sclera, and sometimes these grafts get converted to sclerokeratoplasties if you're not able to suture the cornea itself.
Ma'am, if you have to try C3 for these patients, since it's already 200, like if we take out 40 to 50 microns of epithelium, is that still okay?
Yeah, so
Just
the concept of adaptive fluence is that you're using lesser energy. See, earlier you were doing accelerated cross-thinking where you were using the same energy.
lesser duration.
Power and time were, as per the Bunsen-Roscoe law of reciprocity, if you were increasing power, you were decreasing time. But you were using the same amount of energy. Now what happens when the cornea itself has lesser collagen is that you need lesser energy because there's less collagen to cross-think, and you don't want the endothelial toxicity to come in. Therefore, instead of the 5.4 energy that was traditionally used, you reduce the total amount of energy. Okay? And then you can, sporal has gone as low as 250. Okay? So, but of course, the collagen response of a keratoconus patient and a brittle cornea patient will be different. So there is still not enough evidence to really tell us how well collagen cross-linking works, but now this may be tested more with the adaptive fluence. But the bottom line is, don't try and open a globe till you're sure you'll be able to handle it, right?
Any questions from the house? Any comment from the panelist? So these are rare cases. You have to be extremely cautious about these cases. And first case, it's quite late. Usually, these patients, they present in the first 10 year or 20 year with perforation. The patient is lucky.
It's just an incident.
Yeah, but both of you presented quite well and documentation was perfect. Thank you for that.